Question 131, we've got a 23-year-old female who's complaining of lower abdominal pain, dysphoria, and urinary frequency. What's the most likely pathogen? Right, what's the most likely pathogen in a young female that's got an uncomplicated UTI? Of course, it's going to be E. coli, which is 65 to 80% of all UTI causes. Other causes include Proteus, Klebsiella, Enterobacter, Candida, and Enterococci. You always need to exclude STIs such as chlamydia, especially if they are sexually active. Question number 132, we've got a 45-year-old HIV positive male who's come in with flu-like symptoms and a cough. He's got erythema nodosum and erythema multiforme. Sputum culture confirms the presence of a fungal organism. What is the most likely diagnosis? It's going to be Cryptococcus. And that's because we've got HIV positive male. Oh no, sorry, it's going to be histoplasmosis because we've got somebody who's immunosuppressed and they've got characteristically erythema nodosum and erythema multiforme. Yep, so it is histoplasma capsulatum. Evidence of infection is usually with a positive histoplasmin test, and it usually affects the lungs, so you get a pneumonia or influenza-like illness with fever, chills, myalgia, and cough. You can get a secondary bacterial pneumonia, and then you get other symptoms like pleural effusions, and as in this case, erythema nodosum, erythema multiforme. Question 133. So we've already done this. Oh no, sorry. Is a 30-year-old male who's HIV positive. He's got diarrhea and weight loss. Which of the following is the most likely pathogen? Now it's the Cryptosporidium. Yes, and that's because we've got HIV patient who's got severe diarrhea because they're immunocompromised. And there we go. That's what it looks like in the feces under a microscope. We've got a 5-year-old boy who presents with recurrent sinusitis, upper respiratory tract infections, and chronic diarrhea. His parents have been advised to warn doctors if he has a blood transfusion or intravenous immunoglobulin. Which of the following is the most likely diagnosis? So we've got somebody who can't defend via his mucous membranes. So immediately we start to think of a selective IgA deficiency. Because they are sensitized to IgA, they might develop some sort of reaction when they receive it in blood transfusions or during receiving intravenous immunoglobulins. So this is the correct answer, selective IgA deficiency. Yep, and it's very rare, happens, or quite rare, more common in males, happens in 1 in 300, and there isn't any treatment, it'll just all be symptomatic management. So question 135, we've got a 20-year-old male who presents to A&E with shortness of breath, palpitations, and headache. These symptoms came on soon after he took cotrimoxazole for a particularly resistant UTI. FBC shows ꕰₛⴡ or normocytic anemia. Peripheral blood smear reveals Heinz bodies. Which of the following is the most likely cause of the patient's anemia? So we've got a young gentleman who's taken cotrimoxazole and then he's developed an anemia and he's got Heinz bodies. So this shouts out glucose 6-phosphate dehydrogenase deficiency, which is an X-linked disorder. It's usually provoked by infections, drugs such as quinines and sulfur drugs and favipiravir. They can develop an acute hemolytic crisis, and characteristically we can see Heinz bodies on our blood films. It wouldn't be lead poisoning, although it causes normocytic anemia with basophilic stippling, and the usual features are abdominal pain, headache, irritability, and peripheral motor neuropathy. Folate deficiency leads to megaloblastic anemia, so it wouldn't be normocytic normochromic, would it? It would be macrocytic macrochromic. And hereditary spherocytosis usually doesn't show Heinz bodies on the peripheral blood film. It shows hyperchromatic red cells without a central area of pallor. And then occult causes of blood loss, such as chronic iron loss, would cause a microcytic anemia, as opposed to the normocytic normochronic anemia that we have here. Then we've got question 136. We've got a 55-year-old male who returns from a safari trip in Africa. He presents with progressively high fever, diffuse abdominal pain, constipation, headache, and a cough. On examination, he's febrile, 41 degrees, and he's got a relative bradycardia of 50 beats per minute. He's also got a maculopapular rash on his trunk. His abdomen is distended. You can palpate the spleen. So here we've got someone with fever, constipation, relative bradycardia, and splenomegaly. This you would be quite aware of. Shouts out typhoid. If you are from an African country or have lived in an African country, mainstay of diagnosing it would be blood and blood cultures. So he's got Salmonella typhi or typhoid. Usually it's got 4 stages: the first week, second week, third week, fourth week. During the first week, you usually get the constipation and the abdominal pain. Second week is when you get the soft splenomegaly and the relative bradycardia. Third week is when you develop the pea soup diarrhea. This is quite dangerous because they are prone to developing bowel perforation and peritonitis. Fourth week is when everything starts to slowly improve, i.e. the fever, the mental state, and the abdominal distension. Sometimes intestinal and neurological complications remain in surviving individuals. Usually standard criterion for diagnosis is through the blood and blood cultures. Question 137, we've got a 45-year-old female who complains of feeling hot and cold during her second unit of blood. So this isn't something that's happened immediately. Which of the following blood transfusion reactions has she most likely suffered? So it's her second unit and she's only complaining of feeling hot and cold, i.e. febrile. So it's going to be a non-hemolytic transfusion reaction. And that is caused usually by the cytokines from leukocytes in transfused red cell or platelet components. Symptoms usually happen towards the end of a transfusion or within the next 2 hours, and then symptoms are the fever, chills, malaise, sometimes dyspnea. And then the treatment is stopping the transfusion or slowing it down and giving paracetamol. So we've got 2 parents who are both carriers of cystic fibrosis, which is autosomal recessive. They would like to know the chances of their offspring losing the gene for cystic fibrosis. So what's the possibility that the child will not be either a carrier or affected by the disease? So autosomal recessive means that both of the parents are carrying the disease. So that means that 50% of their offspring are going to be carriers, whereas 25% are going to be affected, and only 25% are going to be non-carriers and non-affected. It's the most common autosomal recessive condition in the UK, and it's due to a defect on the CFTR gene on chromosome 7. And there we go. Only 25% are normal, 25% are affected, and 50% are carriers. Question 139. So we've got a female who becomes acutely short of breath and wheezy within minutes of receiving a blood transfusion. What's the single most likely diagnosis? So this is just minutes, and we've got wheeziness and shortness of breath, i.e. bronchoconstriction. So we're going to go for anaphylactic reaction. So anaphylaxis is when somebody's been sensitized to something and then on re-exposure releases IgE or IgG antibodies. They usually occur within less than 10 mils of blood transfusion, and they get symptoms that are indicative of bronchospasm or laryngeal edema. Mainstay of treatment is oxygen, salbutamol, chlorambenamine, adrenaline. Sometimes you can give hydrocortisone as well, and call the anaesthetist if you've got any issues with the airway. They usually need to stay in hospital for observation. A 24-year-old female has returned from a trekking holiday in South America. She complains of fever, bloody diarrhea, abdominal pain. She's got diffuse abdominal tenderness, done an ultrasound, seen a liver abscess. So that is where the answer is. South American liver abscess immediately makes us think of amoebiasis. So amoebia is called by 𝕊𝕆ᴂ𝕀𝔸𝕃 𝕊𝕆ᴂ𴀜. It is a protozoa and it penetrates the colonic mucosal barrier, and that's why you get all the GI symptoms of bloody diarrhea and colitis. And then the most common manifestation is the amoebic liver abscess. It is infectious via the orifecal route, and also can sometimes be transmitted via sexual practices. Question 141, we've got a 40-year-old male who complains of intense pain on defecation. He has been unable to open his bowels for the last couple of days. On examination, he has a small midline crack in the anal margin. He doesn't let you do a DRE examination due to pain. Which of the following is not an appropriate means of management? So this chap has got an anal fissure, so we don't want to be doing sclerotherapy because that's one of the main ways of treating hemorrhoids. So, but we can go for all the other options. So what is a anal fissure? It's a crack in the wall of the anal mucosa so that the circular layer of muscle is exposed. Usually occurs posteriorly. However, we need to make sure that we're not getting anal fissure secondary to having Crohn's disease. The other issue is the patient usually complains of pain after defecation or passing stools. They usually have bright red blood on paper, and they develop a fear of defecation, which further aggravates their constipation. When we examine, we usually see the posterior anal fissure, and there's something called the sentinel pile, which is nearly always associated with it. And the severity of pain and muscle spasm prevents them from asking you to a DRE investigation. So mainstay of treatment is improving the diet so they aren't constipated, giving topical GTN or botulinum toxins to relax the anal sphincter. If conservative management doesn't help, then we can go for an internal sphincterotomy and manual dilatation. Question 142, we've got a 50-year-old male presents with a small, tender, tense, irreducible lump in the lower part of his abdominal wall on the right side at the lateral edge of the rectus muscle at the semilunar line. What is the most, which of the following hernias is the most likely diagnosis? So we're going to go for Spigelian. And it's a rare hernia, which is a hernia through the aponeurotic layer between the rectus muscle medially and the semilunar line laterally. It's got very high risk of strangulating, usually occurs in the right side, and most people develop it around the age of 50. We've got a question 143, which is a 50-year-old male who presents with colicky abdominal pain, nausea and vomiting. He's got a distended abdomen, tinkling bowel sounds, and he's got irreducible left inguinal hernia. Which of the following is the most likely diagnosis? So we've got 3 out of our core symptoms of developing intestinal obstruction, which is abdominal pain. We've got all 4: abdominal pain, distension, nausea, vomiting. So we're going to go for small bowel obstruction as opposed to ileus, because we've got the tinkling bowel sounds. In ileus, we wouldn't have bowel sounds, or they'd be very low. So small bowel obstruction is usually caused by adhesions. It can be partial, complete, simple, or strangulated. Strangulated small bowel obstruction is very dangerous because it can lead to bowel ischemia, necrosis, consequently leading to perforation, peritonitis, and death. When we have vomiting, that usually indicates that it's small bowel obstruction and constipation, whereas distension proves that we have a more distal obstruction. Symptoms that can make us worry are being febrile and tachycardic, because that can indicate strangulation or peritonitis. So when we do an x-ray, what we can see is dilated lobes of small bowel, and we've got no air in the distal colon. Management is strip and suck, i.e. insert a drip, suck everything out with an NG tube, surgery if there is strangulation or peritonitis. Question 144, we've got a 35-year-old male insurance broker with no previous history of peptic ulcer disease. He presents with new onset epigastric pain and retrosternal pain associated with bloating and fullness after meals. He's tried over-the-counter antacids to no avail. Which of the following is the most appropriate management? So we've got young chap who's not got any alarm systems. He's tried antacids. He's tried his lifestyle modifications, his antacids. It's not worked. Next step is to give a proton pump inhibitor such as lansoprazole. We wouldn't be doing that if he had any alarm symptoms. What are our alarm symptoms? Dysphagia, any evidence of blood in the form of 𝕊𝕆₃ or hematemesis, if he's got persistent vomiting, weight loss, or if there is a mass. So like we said, steps are usually review our medication and lifestyle advice, then we go for a full dose PPI for 1 month. If that doesn't work, then we go for testing for H. pylori, which can usually be done by a breath test or an antigen test. If it's positive, then we treat it and review. If it's negative, then low dose treatment as required. Question 145. So we've got a 30-year-old pregnant female who's complaining of a lump down below, which she's unable to reduce. What's the most likely diagnosis? So irreducible hemorrhoid would make it a grade 4 hemorrhoid, and she's pregnant, which predisposes her to having hemorrhoids. What are hemorrhoids? So hemorrhoids are subepithelial vascular cushions, which are usually at the 3, 7, and 11 o'clock position. The factors, the commonest cause, or they are the commonest cause of rectal bleeding. You can have internal or external hemorrhoids, depending on where they are in relation to the dentate line. They have 4 grades. Grade 1 is when it doesn't come out of the anal canal. 2 is when it prolapses but reduces spontaneously. Grade 3 is when it requires manual reduction. Grade 4 is when it can't be reduced at all. They usually produce intermittent symptoms, and they are precipitated by constipation. What happens is you usually get bleeding after defecation. Sometimes you get fecal soiling, mucus discharge, itching, pain, sometimes rectal mass. Management, you usually go for a sigmoidoscopy if you're worried that you're getting hemorrhoids secondary to a malignancy up above. But your treatment is usually you start conservative with diet, prenatal bath, and you can go for GTN spray, and you can also go for sclerotherapy, rubber band ligation. Sometimes botulinum toxin helps to reduce the spasm of the internal anal sphincter, or you can go for surgical options such as LOD, stretch procedure, and hemorrhoidectomies.